invite the first speaker, Dr. Anupam Singh, Senior Resident in RIO, Sitapur Eye Hospital, Sitapur. And his topic is comparison of optical coherence tomography, angiography, and fundus fluorescent angiography in patients with diabetic maculopathy.
Good morning, everyone. Today, I'm going to present my thesis that is a comparison of the optical coherence tomography angiography and the fundus fluorescent angiography in the patient with a diabetic maculopathy. I have no financial interest in this presentation, as we all know that the diabetes is a growing worldwide epidemic, and in the India, the prevalence of the diabetic macular edema among the people with the diabetic is reported to be 8.9%. And we all know that although the fundus fluorescent angiography is a gold standard and used to assess the leakage in the vascular bed qualitatively in the macular edema patients, but it cannot be used repeatedly due to the toxic nature of dye and various side effects. Whereas the Schweitzer OCT-A is a newer technique which can acquire an image of the retinal vasculature without the need of any toxic or invasive procedure. The aim of my thesis was to assess the effectivity of OCT-A when compared to FFA to detect the various structural features in the patient with a diabetic maculopathy. The research hypothesis was that the OCT-A is a comparable substitute to FFA for the analysis of the retinal vascular pathology in the diabetic maculopathy. The objectives of the study were to compare the ability of OCT-A with FFA to evaluate the following structural damage. That is the FAZ zone diameter, FAZ distortion, number of microaneurysms, number of neovascularizations, number of CNP areas, and number of IRMAs. Coming to the material and method, the study was conducted in the retina department of the Regional Institute of Ophthalmology, Sitapur, with a duration of 2 years. It was the cross-sectional agreement study of the 2 diagnostic tests with a sample size of 102 eyes. The patient who were above the age of 18 years and presented with a diabetic maculopathy were included in the study. Coming to the exclusion criteria, the patients which were not willing to participate in the study and having the significant media opacities like the cataract and vitreous image were excluded from the studies. For the image acquisition, for OCT-A, we use Top Gun DRI OCT1 Atlantic Sort OCT, and for FFA, we use Visucam 500 machine, which is from the Carl Zeiss Optics. To quantify the area under the consideration, we use the Java-based images software. These are the images which are subsequently taken for the study. Now, starting with the result, the best corrected visual acuity in the right eye at the presentation was a 0.84 with a standard deviation of 0.82, and in the left eye it was 0.91 with a standard deviation of 0.91. When compared in between the FFA and OCT-A, we find that there was 0.8% difference in the measurement of the horizontal diameter of the FAZ, whereas the 2.16% difference in the measurement of the FAZ diameter area of the FAZ when compared on the FFA and OCT-A. When Pearson correlation coefficient were applied on these data, we found that there was very strong to perfect agreement in between the horizontal diameter and the area when compared on the OCT-A and FFA. For the microaneurysm, we found that the FFA was better. For the neovascularization, we see that it has been seen that the agreement was observed for the 96 eyes with the kappa coefficient value of 0.90, which shows almost perfect agreement. Almost perfect agreement was also seen for the number of capillary non-perfusion areas. And for the IRMAs, agreement was observed in the 88 eyes with the kappa coefficient value of 0.663, which showed the substantial agreement. Now, coming to the discussion, we found that the horizontal FAZ diameter and FAZ area was showing very strong correlation when compared on FFA and OCT-A. For the CNP, the agreement between the FFA and OCT-A was found to be almost perfect. To assess the burden of the exudation, one need to study the leakage, which can be studied only on the FFA. The limitations of our study was the low sample size, and our OCT-A imaging was confined to the posterior pole, so we were not able to assess the peripheral vascular changes. To conclude, the SS-OCT-A is a reliable, non-invasive and reproducible imaging technique as compared to FFA, and the fovea avascular zone details study on OCT-A shows very strong agreement with the FFA, where the horizontal diameter shows much stronger agreement. These are my references. Thank you.
Thank you, Dr. Anupam. You have done OCT-A and FFA in all the 1 or 2 cases, right?
Yes, sir.
So which one was done first? OCT-A was
OCT-A was done first, okay. And after that we went for the full threshold FFA, sir.
So you didn't first identify the neovascularization, and in that area you did do the
yes,
OCT.
Sir.
Okay, but you mentioned what was the subclassification? How many were PDRs? How many had macular problem? How many cases had a macular ischemia?
Sir, we taken the all patient with the diabetic maculopathy only, sir, whether it is NPDR, macular ischemia or the PDR, sir. We did not subclassify, sir.
No, no, because if you are comparing the identification of neovascularization, you should know how many are PDR, so that the PDR identified by OCT and PDR identified by FFA. Because if the, what do you call, the
Sir, the
yeah.
maximum patient we took was the PDR, but sir, this criteria was not included in the study, sir.
Okay, so how many cases had macular ischemia?
Sir, we have seen that around 92 to 93 cases, sir, having the macular ischemia, sir. But sir, we were not included that in the study, sir.
Okay, so any.
What is your conclusion?
Sir, OCT is a reproducible technique when compared to FFA, sir. So for the subsequent visit, we cannot do FFA to see the progression of the disease or to see the extent of the treatment that the patient is recovering or not. So we can do the OCT-A and we can see that, sir.
Which procedure is better?
Yes, sir.
You think?
So that is the question.
FFA is better, sir. FFA is the gold standard ratio, sir.
Okay, thank you, Dr. Anupam. So we'll have the
Thank
certificate
you.
distributed at the end of the session for all of
Shilpi,
you.
it is only
Yes,
4 minutes. No? That's too less. They have decided anyway. I think it is too less.
Thank you. So the next speaker is Dr. Farina Kulsum. She is a fellow at Sadhguru Netra Chikitsale, and her topic is effect of vitamin D supplementation on PEGF and PEDF in diseases of posterior segment of the eye.
Good morning, everyone. My topic for presentation is effect of vitamin D supplementation on vascular endothelial growth factor and pigment epithelial drive factor in disease of post-segment of eye. So as we all know, the pathological hallmark of the leading causes of blindness is a dysregulated choroidal or retinal neovascularization. VEGF and PEDF is known to have a crucial role in the developmental and the pathological angiogenesis. However, vitamin D is a modulator of oxidative stress and angiogenesis. There are dearth of ocular studies showing the relationship of the same. To fulfill these lacunae, we have undertaken the present study with the following objective. The objective is to study the effect of vitamin D supplementation on the levels of VEGF and PEDF in patients with disease of posterior segment of eye. It was a double-blind, randomized and placebo-controlled trial in which 93 patients were undertaken. Study group contained 60 patients with disease of post-segment of eye, and this was further randomized into subgroup A1 and A2. A1 group received vitamin D supplementation, A2 received the placebo. Group B had 33 age and gender match healthy patients. Fasting blood plasma were collected, and vitamin D and serum VEGF and PEDF was measured at the time of enrollment and after 3 months of supplementation. This was the exclusion criteria. After proper statistical analysis, coming to results. Distribution of cases in the study group, out of 60 patients, mostly patients were of diabetic retinopathy and followed by RVO and ARMD. These patients were randomized to receive either oral vitamin D therapy or placebo for a period of 3 months. If we see at the demographics of the study, difference between the mean age of the patients and the gender between the two groups was not statistically significant. Coming to the comparison of baseline variables between the study group and healthy control, serum vitamin D concentration was found to be significantly lower in the disease group. However, serum VEGF and PEDF was found to be significantly higher when compared to the healthy controls. Out of the 60 patients in the study group, 24 patients were lost to follow-up. Comparison of variables between the intervention and the placebo group. At baseline, there was no significant difference between the mean serum vitamin D concentration. However, at 3 months, the mean serum vitamin D concentration was significantly higher in the intervention group. If we look at VEGF, at baseline, there was no significant difference in the mean serum VEGF. At 3 months, there was significant decrease in the serum VEGF in subgroup A1 when compared to placebo. And similarly, PEDF was also decreased after 3 months of vitamin D supplementation in intervention group. However, it was not statistically significant, but the change in the PEDF was significant. Coming to correlation between vitamin D and study variables, so serum VEGF and serum PEDF was found to be negatively correlated with vitamin D, and this correlation was statistically significant. Coming to discussion, retinal angiogenesis is the basis for vision loss in several major blinding diseases. Oxidative stress affects the RPE, leading to the development of the vascular eye disease. Vitamin D, on the other hand, is a known modulator of oxidative stress and angiogenesis. These are some non-ocular studies in which authors highlight the potential use of vitamin D in both the prevention and the regression of conditions characterized by pathological angiogenesis and inflammation. And in the animal studies also, the authors have proved the same. Despite the reasonable rationale provided by the above discussed association data, prospective studies on the effect of vitamin D supplementation post-segment disease of the eye in humans are lacking. conclusion, after vitamin D supplementation, there was mean decrease in the levels of VEGF and PEDF in the intervention group, and it was found to be statistically significant. Due to anti-angiogenic effect of vitamin D, it can be used as a supplement to the current management guidelines of posterior segment of eye. Thanks, ma'am.
Thank you, Dr. Kulsum. In the intervention group, in the what do you call the study group, you had two groups, one with intervention, one without intervention, right?
Yes.
Even that one which did not have intervention also had deficiency of vitamin D. Why they were not treated? Is it right ethically to exclude them by not treating?
No, sir. Actually, we followed up the patient for. We were in control. We were seeing like they had the vitamin D, but that was not that much low that it.
No, your mean was less than 16. You said actually, yeah. And number two, like any of these patients had macular edema, which warranted any anti-VEGF injections.
No, sir.
Hello? Hello? Hello?
Dr. Salil.
Hello?
Take this mic.
No, sir. No, sir. No, sir. Yes, we do it at the baseline. Obviously,
No, no, they have done. They have done.
Baseline.
The mean was 16.
See, one more comment, Dr. Salil. See, this posterior segment disease, it is a subject. See, there is a number of posterior segment diseases. I think you should have specified a particular disease, maybe diabetic retinopathy, maybe vein occlusion.
Yes, sir.
Instead
I have
of
specified that.
there, but your topic is in the posterior segment disease, isn't it?
Yeah, in the topic it is post-segment disease.
See, posterior segment disease is a general term. It is a book.
Yeah,
You know,
in the inclusion.
for three volume books of Rayan covers the posterior segment disease.
Yes, I
You
should have
be specific. Maybe diabetic retinopathy, maybe vein occlusion.
Yes.
Otherwise, it becomes quite
Yes.
vague. This is
No, I saw headings, three headings that inflammatory,
Edematous and
proliferative and
proliferative.
this. But in the results, you didn't like
I have done
group
in
that and tell the correlation. Maybe that was the thing, right? What was the dosage followed? Vitamin D?
Vitamin D, ma'am, we gave it for one weekly. We give 60,000 unit in the loading dose, and then on the maintenance we keep for rest of the 2 months.
Yeah. And then did you check, after how many days did you check the vitamin D levels?
3 months.
Thank you.
So the next speaker is Dr. Nishi Prasad, fellow at GMC Bhopal.
Dr. DC Prasad is there?
Okay.
Oh, please.
Good morning, everyone. So, my topic is fetal hemoglobin and development of ROP in preterm babies. So, the incidence of ROP in India is very high, 38% to 50%, and only few studies are related to the protective factors. Most of the studies which are published are related to risk factors. So, fetal hemoglobin is one of the protective factors. Only 2 studies in literature have been reported so far between correlation of fetal hemoglobin, blood transfusion and ROP. So hence we choose this title, and our aim of the study was to correlate between fetal hemoglobin concentration, blood transfusion and ROP in preterm infants. This was a prospective observational study for a period of 1 year at GMC Bhopal, and all preterm babies with less than 36 weeks and less than 2 kg birth weight were included in the study. So all preterm neonates were divided into 2 groups, ROP and no ROP. ROP group was further divided into those infants who showed progression, those who regressed after treatment and without treatment. So the concentration of fetal hemoglobin was quite low in the ROP group compared to those in no ROP group. And there was inverse correlation between the staging of the disease and the fetal hemoglobin concentration. Lower the staging, higher was the fetal hemoglobin concentration. Those infants who progressed had lower fetal hemoglobin concentration compared to those who regressed. Blood transfusion and volume of blood transfusion was
positively associated with the development of ROP. So ROC curve, predictive ability of fetal hemoglobin, area under the curve was 0.976 with very high sensitivity and specificity. So the concentration of fetal hemoglobin was less in ROP group, and there was a sharp demarcation at around 56% of fetal hemoglobin between ROP and no ROP groups. Fetal hemoglobin was significantly lower in the ROP group than in non-ROP group. Higher the concentration, lower was the staging of the disease, and the probability of developing ROP and its progression was less in infants with fetal hemoglobin more than 60%. So this is the first Indian study and third worldwide study between fetal hemoglobin, blood transfusion and ROP, concluding that replacing fetal hemoglobin by adult hemoglobin during blood transfusion may promote the development of ROP. Conclusion: replacing fetal hemoglobin by adult hemoglobin during blood transfusion may promote development of ROP. Conversely, maintaining higher levels of fetal hemoglobin may be protective for developing ROP. So our recommendation is that adult blood transfusion should be given with caution in susceptible preterm babies as it dilutes fetal hemoglobin level, thereby increasing the risk of ROP. This is a multi-center randomized trial born study going on, suggesting cord blood cells transfusions to reduce the severity of ROP in extremely low gestation age.
Yeah, time is up.
That's it. Thank you.
So you have any questions?
How will you collect the sample?
Sample was collected for all the preterm infants who had come for ROP screening, sir. We had sent 3 ml of blood sample of the baby to the pathology laboratory for fetal hemoglobin estimation by chromatography method, high performance liquid chromatography method, at the first visit and also at the follow-up after 1 month.
But your study timeline is too short.
1 year, sir. Yes, sir, my thesis was like for 1 year study, and after that, for the last 6 months, we had made tables and discussion. Yes,
How
sir,
many
so the
ROP? How many ROP you seen in your cases? Means your study?
Yes, out of 4, we had taken total 410 preterm infants, out of which 300 was no ROP and 110 was having ROP. So the incidence was 26.8% in our study, sir.
The fundus examination was done immediately after the transfusion, or?
Yes, sir. Yes, sir. Fundus examination was done, and the ROP was staged according to the IC-ROP guideline 3, and then we had sent for the fetal hemoglobin blood for the fetal hemoglobin estimation.
In fundus examination, which stage is most commonly seen in your study?
Sir, those infants who had a lower fetal hemoglobin levels, in them stage 3 was most common, sir. And those infants who had higher fetal hemoglobin levels, they were like kind of protective in our study with stage of 1. Yeah, thank you, sir. Thank you.
Next speaker is Dr. Chinmay from Shankar Eye Hospital, Guntur, Andhra Pradesh.
Good morning, everyone. The topic of my presentation is measured versus posterior coronal astigmatism and calculation of toric IL power. There are no personal interest or financial disclosure. These are the abbreviations used in the study. The role of posterior coronal astigmatism in calculation of toric IL power has been extensively stressed upon in multiple studies. It was initially assumed that the cornea is uniformly thicker across all the meridians, but in fact it isn't the case. The posterior cornea is steeper in the vertical meridian, with the negative connotation of the posterior corneal surface and the PCA remaining against rule across age groups. The total coronal astigmatism is not the same as with rule astigmatism of the anterior coronal surface, but is lesser due to the compensation of the against rule astigmatism of the posterior coronal surface. The reverse is the process that happens in against rule astigmatism of the anterior coronal surface. Hence, a slight undercorrection in eyes with the rule anterior coronal astigmatism and a slight overcorrection in eyes with against rule astigmatism is required. The Barrett's toric calculator is well suited to address this important issue, as the predicted PCA is derived from the Barrett toric calculator's proprietary formula or is incorporated directly from a suitable device. So we aim to compare the prediction error after implantation of toric IL using measured and predicted posterior coronal astigmatism, with the secondary outcome measures being the uncorrected and the best corrected visual acuity, the prediction error based on the magnitude and the type of astigmatism. With this background, we did a prospective interventional study at L. Prasad Eye Institute, Hyderabad, from a time interval of October 2020 to April 2022, and included patients who were 21 years or older, had a visually significant cataract, a regular coronal astigmatism of 1 to 4 diopters of WTR, 0.75 to 4 diopters of ATR in a 6-mm dilated pupil, and excluded patients who had a difference of more than 0.5 diopters in magnitude of astigmatism, 15-degree difference in the axis of keratometry, any patients who had intraocular corneal surgery or clinically significant ocular pathology. All patients as a part of preoperative workup underwent measurements with IOL-Master 700, lens star and oculizer. The surgically induced astigmatism was kept constant at 0.1 diopters. The lens model power and alignment was undertaken using the Barrett's universal formula under the Barrett's toric calculator. Clear corneal phacoemulsification with accuracy of IK toric IOL implantation through a 2.8 mm tunnel incision with the location of incision on the steep axis of astigmatism was done in all cases. After statistical analysis with a significance level of 5% and a test power of 80%, 64 eyes were recruited. The mean IOL power implanted was 20.92. The mean toric cylinder power corrected was 1.64. Superior incision was taken in 28 subjects, temporal 33, superior temporal 3, and a significant improvement in visual acuity was noted at the end of the surgery. The mean absolute anterior corneal astigmatism was significantly higher for IOL-Master total keratometry between the 3 machines. 17 eyes had with the rule astigmatism, 40 eyes had against rule, and 7 had oblique astigmatism. Overall PCA comparisons between IOL-Master and oculizer also showed a statistical difference. This is a bar graphical representation of astigmatism prediction error across devices in all the eyes and subgroups of eyes. When we look into the results of all the eyes, 81.3% of eyes using lens star and oculizer both predicted and measured were within 0.25 diopters. The prediction mean absolute error was lowest with oculizer with the measured PCA. In the subgroup analysis, in the with the rule group, the mean absolute error was lowest with the lens star predicted. In against rule, it was lowest with the IOL-Master measured, and in oblique, it was lowest with the oculizer K predicted. However, no significant difference across devices or calculation methods was observed at the end of the post-operative 1 month. Shamas et al. Compared 122 eyes on SS-OCT biometer and shine plug topographer and concluded that the predicted PCA performed better with the OCT key readings than with the topographer SIM keys and the measured PCA. Lukvich et al. On the other hand compared 24 eyes on Pentacam OPD3 and IOL-Master 700 and concluded that the predicted PCA and PCA measured using IOL-Master 700 produced similar results. In conclusion, we also found out that the Barrett's toric calculator, there was no significant difference in the prediction errors between lens star, IOL-Master, additionally with oculizer as well. Therefore, oculizer can also be used to reduce the prediction error in calculation of toric IOL power. Thank you.
Thanks, Dr. Chinmay. Any questions?
During your implantation of the lens, how will you, which procedure you applied? You do viscoelastic or in the hydrofloat?
Viscoelastic, sir.
Viscoelastic in your toric lens. What is the procedure for alignment of your mark?
We used intraoperative Callisto was there. Intraoperative device was used, Callisto.
And if you put a viscoelastic, when you aspirate the vision, it will be rotate.
Yes.
Any newer procedure you can apply here?
We did a thorough visco wash after the, before the alignment.
No.
So you aligned after washing out the visco?
Yes, yes.
That's what sir meant.
Okay.
This is hydrofloat. No visco. At 10-degree alignment. Then you rotate and align the line. Otherwise, you will be in trouble. High astigmatism, Monday.
Right. Thank you, Dr. Chinmay. Next, we call Dr. Nivedita. Yeah. She'll be presenting on the outcomes of phacoemulsification small pupils.
Good morning, everyone. Successful cataract surgery and adequate pupil dilatation of more than equal to 4 millimeters of paramount importance, and few methods useful for intra-pupil expansion are stretch pupilloplasty, iris retractors, BX ring, Gupta ring. In majority of the studies done on outcomes of phacoemulsification, either a single etiology was taken into consideration or a single method of intervention was studied. And there is no prospective Indian study that has compared BX ring and Gupta ring with iris retractors, and additionally there is no reported study stating residual effect of these devices on the post-op pupil size. Our aim was to study the outcomes of phacoemulsification in small pupils less than equal to 4 millimeter using pupil expansion devices at a tertiary eye care center in South India. Our objectives were to measure pre-op, intra-op and post-op pupil size, to measure surgical time and device addition time, to record the intraoperative and post-operative complication associated with each method, and to record the visual acuity before and after the surgery, to measure pre-op and post-op endothelial cell count using specular microscopy, and to compare the above parameters recorded in each method used. The study period was for a duration of 17 months. The inclusion criteria consisted of pupil size less than equal to 4 millimeter post peribulbar block as study subjects, all grades of cataract and patients willing to participate in the study. The exclusion criteria consisted of active iritis in the past 3 months, current ocular inflammation, posterior synechia more than 1 clock hour, advanced glaucoma with macular trace, specular microscopy count less than 2000 per square millimeter, subluxated lens, corneal disorders and retinal surgeries affecting the visual acuity, posterior segment anomalies, age less than 18 years and patients unwilling to participate in the study. The sample size at 80% power comes to 12 in each group. And the patients with the pupil diameter less than 4 millimeter were randomized into 3 groups. In group 1, we studied iris retractors, in group 2, BX ring, and group 3, Diclofenac eye drops were instilled 3 times at 1 hourly interval, and pupillary dilatation was achieved with tropicamide and phenylephrine eye drops. And thereafter, the patients were screened, and intraoperatively, the pupil diameter was measured to the nearest millimeter with calipers at following steps: before entering the anterior chamber, post OVD injection, and after mechanical dilatation with the device, and at the end of the surgical procedure. Coming to the results, there was no significant difference in intraoperative pupil size before entering the anterior chamber and post OVD injection. There was significant difference in intraoperative pupil size post device insertion in iris retractors when compared to other two devices. Similarly, there was significant difference in intraoperative pupil size at the end of the surgery in iris retractors when compared with other two devices. Significant difference in preoperative versus postoperative undilated pupil size was seen in all three groups. The difference was highly significant with iris retractors. There was significant difference in total surgical time with iris retractors when compared to BX ring, whereas significant difference in device addition time with iris retractors was seen when compared with both the other two devices. Sphincter tear was seen in 2 eyes with iris retractors. Anterior lens capsular tear was seen in 1 eye with BX ring, and in 2 eyes we could engage only 2 flanges of the ring, whereas iris bleeding during iris device manipulation was seen in BX ring. Sphincter tear was seen in 1 eye with Gupta ring. These are my other complications post-operative. Among all three groups, there was no significant difference in best corrected visual acuity obtained in preoperative 1 week post-op and 1 month post-op respectively. Similarly, no difference was seen in endothelial cell count. So in our study, iris roots provided maximum dilatation.
Dr. Nivedita, your time is up.
Yes.
Yeah, okay.
I'll skip the discussion. 15 participants were known case of diabetes mellitus and 9 eyes had PXF. Maximum residual effect was seen with iris retractors. Ma'am, intraoperatively iris retractors provided maximum intraoperative dilatation, whereas both BX and Gupta ring provided comparable intraopupillary dilatation. The residual effect post comparing undilated pupil size both preoperative versus post-op, it was maximum with iris retractors, but it was seen with all three devices.
Hello?
And the operating time was more with iris retractors as compared to other two devices.
In which stage of the vacuum emulsification you do capsulorhexis? Which stage of the vacuum emulsion you do capsulorhexis?
After inserting the device, sir.
After inserting the device.
Yes, sir.
Then what is the choice of your retractor? Means which retractor helps too much? You can apply in all the cases.
So
Understand my question?
Personal or
ID shook, BHEX, you mentioned, na, Gupta's ring. Which device is most used in all the cases?
Commonly used device.
Gupta ring?
No.
In a
most
severe
commonly
synetia, you
used-
can apply the Gupta's ring?
No, sir.
Then
Sorry.
I asked the question. Na?
So you had certain exclusion where more than one clocked
Yes,
arc,
sir.
if you
Yes,
had
sir.
a posterior-
Yes, sir.
posterior
Yes, yes, yes.
synechium. So sir is asking if you have a, say, 4 clocked arc of posterior synechium, which ring will you use or which device you will use?
So first we will do posterior synecholysis and then
Then, how many ID shook you applied? And which is the design most commonly used?
In your study, how many iris hooks did you use? In
4,
the
sir.
4.
4.
What are the most common cause for basically intraoperative melissus?
Most common cause, sir. Sir, in like 15 cases had diabetes mellitus, sir. Like if we come to the ocular causes, 20 cases we don't know the cause, and 9 cases had PXF.
IFS? What are the
IFS was seen in 1 eye.
grade 1, grade 2, like that?
We didn't grade it, sir.
Did you randomize the cases or what?
Yes, sir. Yes, ma'am. Block randomization. We made the chits with all 36 cases, and the random person was assigned to pick the chit after the patient was selected. We didn't know the device till we give the block. After the block, we decided.
Okay, thank you.
Thank you.
Yeah, the next one will be Dr. Gaurav. Is there? Yeah, he's going to present to us on the clinical study of visual prognosis of RVO in relation to posterior segment OCT.
Good morning everyone. Today I'll be presenting on the topic of clinical study of visual prognosis of RVO in relation to posterior segment OCT parameters. To begin with, aim of my study was to study visual prognosis of RVO based on the optical coherence tomography parameters to evaluate SD-OCT features associated with the baseline vision and visual outcomes after 3 monthly ranibizumab doses in the prospective study conducted during December 20 to May 22. My inclusion criteria were all the diseases diagnosed with the RVO. Patient has to be conscious, cooperative and well-oriented. The exclusion criteria was patients who have received previous intravitreal anti-VEGFs and other retinal pathologies including diabetic retinopathy and rest of the pathologies. Also hazy media and vitreous hemorrhage were excluded. These were the materials and methods used throughout the course of study. So the main biomarkers which we used were central subfield thickness, hyperreflective foci, drill, AIOS-ARC junction break, neurosensory detachment and retinoschisis, and they were analyzed on univariate and multivariate regression analysis. So these are the few actual patients OCT scans which shows intraretinal size more than 15 microns, central retinal thickness more than 500 microns. Coming to the observation and result part, most common age group which was affected with the RVO was 56 to 65 years of age. Almost 38 patients were affected in this age. Male preponderance was noted. Then out of 100 patients, 53 patients were of BRVO. 54 patients were presented with the poorer visual acuity at the time of presentation. Of all patients, CRVO counts for 61% of the patients who had poorer visual acuity at the time of presentation. Drill as well as neurosensory detachment were the most common biomarkers noted. So association of the biomarkers with the visual acuity, size of cyst less than 15 micron accounted for the good visual acuity at the time of presentation, that is 76%, whereas retinoschisis and hyperreflective foci had poorer visual acuity at the time of presentation. Neurosensory detachment had shown most common association with the BRVO as well as CRVO. So effect of ranibizumab on these biomarkers, neurosensory detachment, AIOS-ARC junction break, drill and logMAR vision less than 1 has shown statistically significant correlation with the ranibizumab. In this particular table, logMAR vision pre-injection as well as post-injection is noted. Pre-injection it was 1 and after injection it has improved to 0.4 which is statistically significant. Also central retinal thickness which was pre-operatively 488 micron has reduced to 278 microns. After multivariate regression analysis, we came down to younger patients, size of cyst and CRT are important for the visual prognosis. All this data has been correlated with the different studies, Haire, Fong et al., Kang et al., as well as Ota, Glen Yu et al., and Chazari et al. Differently compared. Coming to the conclusion part, univariate analysis, retinoschisis, hyperreflective foci have poor baseline vision, whereas cyst size less than 15 micron have better visual acuity at the time of presentation. Neurosensory detachment, AIOS-ARC junction break, drill, logMAR vision less than 1, central retinal thickness less than 500 have shown better response to injection ranibizumab. After multivariate analysis, younger patients response better to the treatment. Patients with cyst size less than 15 micron had better visual prognosis and central retinal thickness is good visual prognosis. These are some actual photographs of the patients who have shown improvement after the injections.
No, the time is up. The time is up. Yeah. Any questions?
Is there any other systemic association? Like
most of the patients were hypertensive, but we haven't included the systemic distinction between the study population.
No, the question is, anybody is diabetic in this 100 cases? No diabetic, only hypertension.
Only hypertension, only patients with RVOs.
Did you have to repeat any injections?
Yes, at the first, when patient arrived to us and diagnosed with the RVO, we took the OCT scanning. After giving first injection, we followed up the patient for the second, 1 month after the first injection. We assessed the data and on that basis we decided whether to give the second injection or not. Those patients who received second injection, after 1 month after that, we assessed those data also. And patients who received third injections, we did not include those data in this study. But patients who had shown improvement after 1 injection only, we have followed up that patient after 3 months and included that data as well.
Why that patients who didn't improve after 3 months were not included? Because that will have a bias on your results, right?
Yes, sir. But due to limitation of time period and also difficulty in following up the patients in the rural part of Maharashtra, it was difficult to really cope up with that. Yes, ranibizumab lucentis we had used 0.5 mg pre-filled in all the cases. No, sir. It was it was a thesis topic. It was a research topic, so it was funded by institution only. We do get research fundings from the institution throughout our thesis, so we do provide.
No, forget about that. Actually, that is not in the. It's not relevant to this. Yeah, it's not in this. Okay. Thank you very much. Thank you.
Thank you.
Ayush. Dr. Ayush will be talking to us on the progression of bilaterality in unilateral primary congenital glaucoma.
Very good morning to everyone present. Today I'm here to discuss our work on the topic progression to bilaterality in unilateral PCG done at Dr. Rajendra Prasad Center, AIIMS, New Delhi. So as we know, the incidence of unilaterality in PCG ranges from 15 to 35% in published literature, and the unaffected healthy fellow eyes of these individuals are believed to harbor form fruste of the same disease. However, there had been no long-term incidence study to see how many of these initially unaffected fellow eyes eventually develop a rise in IOP or frank glaucoma. On reviewing literature, we could find only two studies, one done by Dr. Bayoumi in Egypt, in which there was a retrospective review of 56 unilateral PCG patients, in which they found that the unaffected fellow eyes differed when compared to healthy control eyes in terms of having higher IOP and higher CD ratio. And the other study done by Dr. Zia, which was a retrospective review of 7 patients over 17.8 years, in which they found that none of these fellow eyes eventually developed disease. So the primary objective of our study was to address this lacuna in literature to evaluate the incidence of rise in IOP in the fellow eyes of unilateral PCG patients, and to see if we could identify any risk factors and to correlate these with AIOS-ARC findings. We included unilateral PCG patients who had a minimum of 5 years of follow-up in our glaucoma clinic, and then called them for a review examination and collected their clinical parameters. In our study, we defined progression to bilateral disease as an increase in the IOP to more than 21 millimeters of mercury on 2 occasions, either without an increased cup disc ratio, which was termed ocular hypertension, or with signs of glaucomatous optic neuropathy, which was termed frank glaucoma. High resolution AIOS-ARC images for the angle structures was obtained, and we looked for the presence of markers of angle dysgenesis, namely the absence of a clearly discernible Schlimm's canal and trabecular meshwork, and the presence of a hyperreflective membrane covering the angle recess, the putative Barkhan's membrane. We also looked for the presence of a patent supraciliary channel, which in some studies has been hypothesized to serve as an alternate route for aqueous drainage. Coming to our results, we were able to recruit a total of 54 eligible patients, and over a median follow-up duration of 8.2 years, we found that a striking 31% of these initially unilateral eyes progressed to bilateral disease, with 15% developing ocular hypertension and 17% progressing to frank glaucoma in both the eyes. Most of these patients were found to develop bilateral disease in the age group of 5 to 10 years. On comparing the dysgenesis parameters on AIOS-ARC between the affected and fellow eyes, we found that they did not differ significantly when we compared the absence of Schlimm's canal, the absence of trabecular meshwork, or the presence of the hyperreflective membrane, thus suggesting that these eyes harbor a similar level of dysgenesis from the beginning. However, on comparison of the patent supraciliary channel, we found a significant difference, and with the presence of this channel, the odds of not progressing to bilateral disease was found to be 1.48. On comparing the risk factors for progression, we found only one factor, that is the corneal diameter of the fellow eye, which differed significantly between the progressor and non-progressor group, and with fellow eye corneal diameter of more than 12 mm, the odds of progression was found to be 9.5, which was statistically significant. When we compared the AIOS-ARC parameters between the progressors versus non-progressors, there was no difference, suggesting that these parameters cannot be used to predict which of the fellow eyes will eventually develop disease. To conclude, progression of unilateral PCG patients in our cohort to bilateral disease was found in 31.5% patients, 15% developing ocular hypertension and 17% developing glaucoma. Corneal diameter of more than 12 mm emerged as a strong predictor as to who will develop bilateral disease, and the presence of a patent supraciliary channel could possibly be protective, emphasizing the need for regular follow-up with close evaluation of these fellow eyes so that early detection and timely intervention can take place. Thank you.
Yeah, thank you, Dr. Ayush. Yours is a PG thesis, right?
Sorry, sir?
It's a PG thesis.
Yes, sir.
But you said the follow-up is for 8.2 years.
Yes, sir.
So how come this was done in
So
3
this
years'
was
time?
an ambidextrous study. Most of these were retrospective patients who were already following up in our glaucoma clinic.
Correct.
So we chose those patients who had a minimum of 5 years of follow-up already, and then we called them up for a review examination.
No, but
So
ideally, thesis should be prospective, right? It cannot be retrospective,
Sir,
ideally.
this was an ambidextrous study. We
And
were recruiting new patients as well.
When you do the initial eye examination, did you do ASOCT both eyes?
Not in the, sir, when at the time of presentation, first presentation of these kids, they were usually infants who could not cooperate for ASOCT. These ASOCT images were taken on the last follow-up examination in which we had called these patients, and only those patients who were cooperative enough for ASOCT were included in the study. Sir, age-wise, we could see that even older kids, like 7 to 8-year-olds, some of them were not cooperative for ASOCT, and even younger kids sometimes, when we like forcefully put them on the ASOCT machine, they were able to cooperate. So I believe the bias of age versus this ASOCT acquisition did not matter.
Do you do any examination under anesthesia?
Sir,
in
examination
patients?
and anesthesia was done at the baseline level and also at the time of surgical intervention for these patients in the initially affected eyes.
Do you do the gonioscopy in both eye, any stage in baseline?
Not for every patient, sir, but yeah, gonioscopy, intraoperative Swan Jacob gonioscopy was done in most of the patients, but we have not included gonioscopy parameters in our study.
What about UBM?
UBM, actually, sir, since it's a retrospective, yeah.
It is uncooperative. UBM would have tripped you a bit.
No, on the follow-up examination in which we have done the ASOCT imaging, it was not done under anesthesia. You're saying UBM on an office basis? That was not taken as part of our study, sir. We did only ASOCT imaging. Sir, because ASOCT, even though
Maybe machine is not available.
Right, thank you, Dr. Ayush. The last speaker will be Soumya Sri, Dr. Soumya Sri. Dr. Soumya Sri is not there actually. Yeah. Okay, with that we conclude this session. I think some of you will be making it to finals, so I think the finals is at 2 o'clock. So we'll have the certificate distribution for the speakers and the
I think they will do, sir.
Dr. Anupam Singh.
Put your name and signature. Yes, sir.
Dr. Farina Kulsum. Dr. Nishi Prasad. Dr. Nishi Prasad is not there. Okay. Dr. Chinmay. Dr. Nivedita. Yes. Dr. Nivedita. Dr. Gaurav. Dr. Ayush. Dr. Amit Raj. Dr. Amit Raj. Dr. Omkar. Dr. Subramania. Dr. Salil Kumar. Yeah, just a minute, ma'am. You can. O'clock actually for the finals of this session. Thank you once again. Thank you.